know me, my name is Liz Lottering. I'm the National Waiting List Information Services Manager with responsibility for national publication of waiting lists and national policy in respect of waiting list. This morning I'm going to be talking to you about the need for the new waiting list guidelines, number one. Number two, how Ireland is not unique in this need. Number three, the new quality assurance programme, and that will then again drill down to the need for the requirement of a new national waiting list policy. I always like using this slide because these are 5 patients who are treated by the National Treatment Purchase Fund. I always like to remind myself when I'm giving these, always like to remind myself when I'm giving these presentations why we're actually here. We're all here as a group of people to try and treat patients safely and as quickly as possible. It has been proved both nationally and internationally that waiting list management policies in hospital, from nationally led and hospital led, does improve waiting list times and does improve the safety for patients. So from an international point of view, the Council of Europe in 1997 asked a group of international people to come in and take a look at the management of waiting lists within hospitals in Europe. They made a very clear statement, and I think it's really where we're at today, so I think it's worth looking at. Delays in accessing healthcare have considerable importance to the public and reflect poorly on healthcare providers. Provider organisations should ensure that access issues are addressed at board level and responsibility taken by the Chief Executive. Organisations should have an explicit policy for the management of waiting lists, and responsibility should be given to a senior manager or clinician. And you'll see this is exactly what we have seen. The organisation's waiting list policy should be part of the hospital's quality assurance programme. It should include goals and objectives as well as covering details of administration and management of waiting lists. Improving waiting times is not a one-off process of clearing backlog of waiters, but an ongoing project to balance demand and elective care and supply of treatment. And I think that is exactly where we are at the moment. We have gone through a process over the last year with PTLs, etc., trying to clear our background, and we're now in a position to bring some structure to that. I'm going to ask you all here in the room, how many of you remember this? Can you put your hands up? Okay. Over the past 6 months, myself and my staff have been doing what we call a new quality assurance review, where we take a look at the adherence to this national policy that was delivered in 2009 and that was circulated to every hospital in the country by the truckload, I'd say. It was signed off by the Department of Health and Children and HSE and signed off by the ministers. So we're now probably nearly 3 years later. So the actual review, the aims were to confirm that hospitals were adhering to the guidelines, that the data returned was accurate so that we could stand up at a national level and say this is right. And it comprised of an on-site review of 3 days, with me and my staff going into the hospital and logging on to systems. So we completed a questionnaire, we reviewed the supporting documentation. In other words, if you said you had a policy, we said show it to us. If you said you had an SOP, we said show it to us. And we looked at that in comparison to the national policy. We looked at the kind of data you were looking at and the kind of data you were looking at from a waiting list management point of view, and where necessary we confirmed medical notes or patient contact. And before I show you the high level results, I just want to show you some comments, because I just want to remind us we're at 2012, this policy was delivered in 2009. And while some of them might seem funny, it's actually in 2012, considering these policies have been around for the last 3 years, quite concerning. So just to show you a few of them here, that patient was suspended 7 times. That patient DNA'd 4 times, but he's definitely coming to the next one because I spoke to him personally. I love that one. We don't do that procedure, we never did, yet there were 30 patients on the waiting list for that procedure in that particular hospital. We don't have a waiting list steering group. We have a waiting list steering group, but it hasn't met for months. All admissions are picked off the waiting list the week before by the consultant, and that was regularly in 10 of the hospitals we were looking at. So we're now in 2012, the times of notice and patient care, etc. So I'd say most of you looking at this at the moment could say we're possibly in the same situation as that. Okay, so all that led us to the overall results of the actual quality assurance. We've only gone to 10 hospitals, quite a few of you are in the room at the moment. Local hospital policy in place that met with the 2009 policy, 4 out of 10. 2 had nothing and 4 had policies in draft, usually for about the last year and a half. Steering group in place, about 8. But there was no terms and reference for most of those steering groups. In other words, nobody knew what they were doing, what they were set up for, or what kind of communication policy they had for the rest of the staff around the agency. All specialties returned, 8. Training program in place for clerical staff, 3. I actually thought this was quite concerning as well, because we've had massive movement in our clerical staff recently, particularly with the retirements, etc. Sample audit in place, in other words, yes, those hospitals, great, had policies, SOPs, but were their staff doing it? Nobody was checking, nobody was seeing did anyone require more training, etc. Chronological booking in place, 2. And shared booking templates in place, 2. What's really interesting is the 2 hospitals that had chronological booking in place and shared booking templates in place were the 2 hospitals that had a really robust policy and had terms of reference for the waiting list steering group. So it all goes back to the need for a new policy, and the main thing that was important about that new policy was that governance was covered in every agency or every hospital delivering treatment in the country. So what we're now saying is waiting list policy should be top down, bottom up. Communication should be coming from the top right down, and there should be mechanisms for communication to come through mid-level managers to senior managers to top-level management. Okay, so moving on. This is the new national waiting list policy. It's in draft format, and the reason why it's in draft format is you are the people managing the day-to-day on the ground. We want to hear back whether this is workable on your site or not. We want you to communicate with us over the next 2 to 3 weeks, and then we see this policy going into lovely publication mode and lovely blue or green colours again and around in every hospital in the country. Jenny Hogan's here today. Jenny has worked with me on the policy for about the last 5 months. So please email Jenny, and we'll use that as a route to set up a grid, and then we'll get back into a room and we'll go through it page by page again, and we'll make any amendments that are coming through from quite a few hospitals. Or if it's a case that maybe something is not explained and it's not understandable in the format that it's in, we need to know about it, okay? So we're asking you to do that in the next 2 to 3 weeks. Okay, so the policy is divided into 4 parts. Number 1 is what you must have in your hospital for implementation of waiting list management. Number 2 is the new categorisations for waiting list management and for publication of your waiting lists and for tracking of your waiting lists. Number 3 is the changes in your operations and procedures that should match that. And last but by no means least, which I've discussed earlier, is the quality assurance review will keep going. And this is meant to be a supportive mechanism that we come in, and where we see issues, we will give you an actual plan on what needs to happen and what needs to change on the ground in your hospital with agreeable timeframes to that. Okay. So the prerequisites. Leadership and governance. I cannot speak more clearly from what we saw about how important the first few pages of this policy are on governance. And more or less, if you follow or implement more or less the first 3 pages of this policy, I genuinely think everything else will fall into place after that. Okay, so your prerequisites for implementation. You must have a steering group. The accountabilities must be defined as part of that steering group. Who is responsible for what, etc. If you have a steering group in place, look at what is on your steering group. Does it give you the power you need? Does it give you the criteria to make changes where necessary? A local waiting list policy outlining your governance must be in place, and a dedicated executive lead must be appointed who is over both booking and waiting list management policy. Because there's no point in you saying that waiting list management is going to have shared booking templates and we're going to have chronological if bed management are doing something else. Okay, so this has to be all cohesive in your hospital. Data and information. Oh, sorry, where am I? Sorry, I got one step back, sorry. Sorry, that went back. Sorry, so these are the prerequisites for implementation. Leadership and governance, and I've just discussed that. The second main point, if this is in place, everything should fall out of it. Data and information. Use your systems. Ivan was talking earlier about your system and the type of information they pulled out. That was pulled out in Excel. So we would be going around hospitals on a regular basis who would tell us, look, we can't get the information we need out of our systems. Most of you have Crystal, business objects, etc. You should be able to pull out what you need. Use your systems to define KPIs on a weekly basis, on a monthly basis for your waiting list steering group, so they have the information they need. Types of things you should be looking at is obviously your PTL breaches, etc. But also you should be looking at your patients who are cancelling twice, etc. Patients who are DNAing once. So in your core waiting list management, to see if you actually have problems on the ground. And that will feed into core management prior to getting to problems with PTLs. Risk management and contingency planning. Ensure that you have a risk management policy and escalation policy as part of your waiting list management policy. And what I mean by that is there is no point in getting into trouble on a Friday evening and panicking. You need to be in a situation where you can preempt situations, you have your risk management policy in place, and people can meet around the table for an hour on Wednesday to say, look, we're heading in a direction, we need to get this sorted before we actually have a problem next Monday. Communication and engagement. Ensure that your communication chain is in place. Everybody knows who they're responsible to, who they report to. So in other words, if it is a situation where you have a designated executive lead who is responsible for booking, that level of communication needs to go up to that person and downwards to the clerical staff again. Okay, we've all seen this little diagram, and I know most of you are waiting for actually to have a planned waiting list and indicative treatment date, okay? This is the new way that patients are going to be reported from a national point of view. So in other words, every patient in the scheduled care system is divided into waiting list or planned procedure. And then your waiting list is divided into patients with a date or without a date. And then you would have your planned taxonomy with an indicative date for treatment, and I'm going to talk a little bit about that more, but just to let you know, for most of you, what that means is you will now have an active waiting list that includes patients booked, unbooked, suspended, or repeat, we'll say planned waiting list that is for patients who are due to have treatment in the future. In the next couple of months, you'll start to see changes in your system whereby there will be a new field on your actual PASS system where you can select that a patient is a planned procedure, and you can select the date they're due for their treatment. So all of you have known the problems we've had with surveillance patients, planned patients, etc. The idea now is that you can track these patients properly and you can track whether they're getting their treatment at the right time or not. So for example, if you have a patient for a cystoscopy today who's due another cystoscopy in a year's time, you actually click the planned admission and then you click the date they're due for their treatment and they shoot off your active waiting list, okay? Okay, so core operational procedures, what is new, which is the third part of it. Adding patients to a waiting list, there is a minimum standard of information. One of the things we came across in the audits is a lot of operational people were not getting enough information to either book patients or to validate patients when they weren't there. They must get on to the PAS or his system within 72 hours. So in other words, and the reason for the 72 hours there is if cards are coming up on a Friday evening, etc. We do not want any boxes, etc., labels on doctors' arms, cards in pockets, etc. So the process in your hospital needs to be that the minute a clinic is finished or the minute somebody is put on a waiting list, it goes to the core area that gets a patient on the waiting list, be that the secretary or the bed management office. Priority, only two priorities, and Ivan will talk about that again later, routine or urgent. ICD 10 AM procedure coding at 100%. we had to manually code some procedures in the system to ensure that GI scopes got their treatment earlier. If you do not know what a patient is on your waiting list for, you can't count, you can't submit them for initiatives, you cannot look at what you need to do for the future if the procedures aren't there and you don't have some type of code attached to them. Policy for adding multiple procedures. This is again where you have patients who may be on the waiting list for a couple of procedures. For example, somebody's on the waiting list for a scope that requires, we'll say, something like a varicose vein procedure. If they're admitted for one, they shouldn't actually be at that time on the waiting list for a second one, so it gives you a way of managing those patients. Scheduling patients. Establish your centralised booking office, and we were only talking about this earlier. The importance to me is not necessarily having one booking office where everybody is booked through. It's important that somebody is responsible across the ranges for all those booking offices, and each ones are following the same type of policies or procedures. Shared booking templates must be established. Guys, the reason why there was no chronological booking in 8 out of the 10 hospitals that we reviewed was because none of them outside those 2 hospitals had shared booking templates. And shared booking templates are basically that you sit down and you agree with the consultant the percentage that your clerical staff can book and the percentage that he needs for his urgent patients. And that is your chronological booking. And that is what is missing at the moment in the hospitals we're visiting. Maximum advance notice of 6 weeks, minimum of 2 weeks where possible. And preferred booking method, telephone or advise patient in writing to contact booking office. The reason why we're saying telephone is, if a patient declines, it gives you an opportunity to offer them a second date. It also gives you the opportunity to let them know if they decline the first date, the likelihood is they're going to be taken off the waiting list when they decline the second date. And again, all that information should be put up on the PASS system so the person coming behind you knows that this patient has already declined a date. In writing to contact the booking offices where you send out a letter to say, not with the patient, not with the date the patient is due in, but that they should contact a direct number to schedule their appointment. And the reason for that is a lot of the addresses aren't right, guys. A lot of the stuff is going to people who've moved, etc. So you're actually giving allocation and spots to people that shouldn't be getting them. DNAs and CNAs. CNAs with notice, twice removed from waiting list. Advise patient again on the second offer that they will be removed from the waiting list. So in other words, you offer them once. If they say I can't make it, you say, do you realise it is national policy that the second time we're offering you a date, you say no again. Unfortunately, to make way and to make it more accessible for other patients, we're going to have to take you off the waiting list. DNAs, 1. A bit of work has been done on DNAs, and I know some of you are going to be delighted when you hear this. We took a look at patients who DNA'd once. The likelihood of that patient DNAing a second time is 87%. So you're wasting beds and you're wasting time. So a patient DNAs once, they are straight off the waiting list. The only person that should be able to reinstate those patients is your designated executive lead in consultation with the consultant involved. Okay, suspensions, clinical and non-clinical. Suspension rates volumes should be heading towards 3% from a national point of view. As your waiting lists start to move back and as your PTLs are working, you should not have high volumes of suspensions. Non-clinical should be kept at a minimum, and that should be not a problem to you if you're using the telephone booking system, because you're giving the patients the opportunity to a second date. If they don't accept the second date, they're off the waiting list. Maximum 3 months, and should only be used once suspensions, okay? Because if you start to use suspensions on multiple times, if the wait times go back to 9 months, 6 months, you're going to have problems with patients reactivating, and that's what caused problems for most people dealing with the PTLs. Core operational procedures. This is all in the guidelines, but I know there's going to be questions. But what I would say to people is the measure I would use to say what will be a planned procedure is that definition. Patients who are waiting to be recalled to hospital for a further stage in their treatment or surgical investigation with specific timescales. So anyone who can't be treated at the moment but can be treated in the future, that's where you use the planned indicative date for treatment. And we'll be working with hospitals in the future as soon as you get that additional field to try and shift the data that you currently have in your active system into the plan procedure grouping. But examples will be surveillance, repeat, and we're all killed with them, so I'm sure you all can't wait to get them transferred into a plan procedure. But it will also allow you to start monitoring whether those patients are getting that treatment when they should be. Number 2 will be bilateral, so right and left hips, right and left knees, right and left eyes, we all know them. Time procedures will be patients who are going through various phases of treatment. So in other words, if you have patients with major scarring who maybe the consultant wants to treat in 3 episodes, that is how you manage those patients on your system, because they are not ready for treatment until the consultant thinks they're ready for treatment. And again, staged. Okay. So the main items to look at, and this is just a little refresher, the main thing you should take out of the room, as far as I'm concerned from a waiting-list management point of view, is implement or review your steering group to see you have the right people on it. Make sure you have clinicians around the table, make sure you have theatre managers around the table, make sure you have somebody at a high level when decisions need to be made to open beds, close beds, etc., that somebody is there that can do that. Agree local policy, include in policy who is responsible for what and what the escalation policies are. If you're a bed manager or waiting list lead on the ground on a Monday, you know you're not going to hit your targets by Friday, that is the time to grab those people around the table to ensure what happens needs to happen. Define your weekly and monthly KPIs. Give that steering group the weekly information they need to do their job. Appoint designated lead who are responsible for all waiting list staff and booking teams, so that each one aren't pinning against each other all the time. It needs to be hooked onto one person and everybody working within that stream. Implement training programs and audit the adherence. In other words, but I do have to say one thing, guys, from an admin point of view in the room here. When we were doing audits, the one people that had got the message and were doing their job and on DNAs by 2 and on follow-ups and were the clerical staff on the ground. What they were missing was what I would like to call is a push from the overall organisation in respect to bits and pieces where they were coming across issues such as capacity, etc. And last but by no means least, use me and my team to help you. Initially we're there to help you. If we see problems, we have the time to go through your system for 2 days to see what your initial problems are, and use our report at steering group to get the changes needed and necessary. It's sometimes good to have an outside influence and an outside person who's going to make a report. So again, last by no means least, this is an industry standard that's used across most industries, and I think it's interesting because it's actually what we should be doing. Okay, so it's number 1, identify your standards, which we are doing in this document of what everybody should be doing around the country. Number 2, collect the data on what you're doing and where you are and how you are meeting that. Number 3, compare where you are to those standards and plan your necessary changes and what has to be put in place. And then you implement your change and you re-audit, and then it starts again and it starts again until you drill down to where your issues are. So I'm just going to hand you over to David with the toolkit, who's going to talk to you about some of the data stuff in relation to this. So thanks very much to everybody.
Hi everybody, my name is David Hamill and I'm a consultant with PA Consulting based in Dublin. I was a member of the core team which conducted the 6 hospital visits earlier this year, so some of you in the audience probably recognise me. So the aim of this session is to, at a high level, present an overview of the toolkit for performance improvement in scheduled care related to waiting list management, the contents of the toolkit, and also ways in which you can use the toolkit. So I think each of you should have getting a hard copy of the toolkit before you come into the room, but I just want to start by saying that there's a lot of information in the toolkit, which is a good thing because it's a support resource aimed at providing tactical solutions for improving performance in waiting list management, and also that it's probably a relatively new concept to a lot of you. So, you know, the idea is that we're going to put this online, make it as interactive as possible, so it's as helpful as possible to each of you in your everyday roles. So the first thing is that the toolkit is essentially structured by the 5 main pillars that we structured our visits and the subsequent action plans that come out of that. So namely leadership and governance, data and information, process improvement, risk assessment and contingency planning, and finally, comms and engagement. So who's the toolkit aimed at? So firstly, it's aimed at providing whole system changes and areas of focus for senior management and clinical leadership. But in addition to that, it also focuses on providing solutions for operational changes based on areas identified in this upper stream for key operational and medical staff. I think it's important to note at this point, and it was mentioned by Alan in his opening session, that right now the toolkit focuses on waiting list management, but we do see this being added to over time in the other areas such as demand and capacity planning, booking and scheduling, and ensuring efficient use of resources. So essentially, over time this toolkit will become, a one-stop shop for improving performance in all areas of scheduled care. So just to talk to the toolkit a little bit now itself. So it's basically, there's two main elements to it, okay? So the first is what we call, I guess, an organizational assessment, or a self-assessment tool, if you like, which enables each of you to identify areas of development or improvement for the hospital. So when I say areas for development, I mean areas for development within each of these 5 areas. And then once you've identified those development areas, the second part of the toolkit prompts suggestions for improvement actions to take to improve, I guess, your standing in each of those areas. So I'm just going to talk to the first part first, this self-assessment piece. So essentially the self-assessment piece, it's structured by those 5 main headings, and it's basically a series of statements rated on a 3-point scale from underperforming, acceptable, to best practice. So it's important to note, when completing this self-assessment tool, it's best to be as honest as possible. We don't expect anyone to be best practice on everything. Rather, it's an evaluation of a point in time, so to help you identify what are like development areas, and then you use the second part of the toolkit to address those areas, okay? So right now we have this in an interactive Excel tool, which I'm going to show you. But again, the idea is that this will be available online, so that you could go on and access it and complete it there. So I'm just going to switch over now to show you quickly. Okay, so just taking the first one, okay, so leadership and governance. Now I realize you probably can't read the text, but I'm just going to read the first statement as an example. So the first statement is related to the waiting list policy, okay? So underperforming would be defined as the hospital does not have a published waiting list policy setting out roles, responsibilities, accountabilities and procedure for the management of the waiting list. And then the opposite end of the spectrum, best practice, would be defined as the waiting list policy is published, reflects the NTPF waiting list management policy, and is actively used across all specialties to manage waiting lists. The policy underpins all waiting list management procedures within the hospital and is actively updated to reflect best practice. Okay, so based on where I would evaluate the hospital to be at this specific point in time, I would essentially click on which is the statement which most closely matches the current situation, okay? So just for example for now, I'm just going to click on random ones, and as I said, it goes through each of the 5 areas, so data and information, process improvement, so forth. And then essentially what you will get at the end is you get a summary of your scores, okay? So you get the absolute numbers for each of those areas, and you'll also get a visual picture, okay? So based on that, I would see that, I guess the areas for development, or most development, would be data and information and comms and engagements. So again, this assessment tool would then help me, identify those areas I need to focus on, and then use the second part of the toolkit, which I'm going to speak to now, to address those. And then in 6 months' time, say for example, after I've developed an action plan to improve each of these areas, use the toolkit, other resources, I would go back in, complete the self-assessment again, and see where I currently stand. Okay? So the second part of the toolkit is it's structured under those 5 headings. So this particular slide here is an example from leadership and governance. So each section follows the same structure, so hopefully it's pretty easy to follow. So the first part we start off is we set out what best practice looks like, okay? And in this case it's for what the structure of the organization should be. And again, this is related to leadership and governance. Then we list what a number of the potential issues could be. So for example, unclear reporting lines, hampering the clarity of ownership of the problem. So essentially I would run through each of these issues and then see which ones are applicable to my hospital or my situation. And then for each of these issues we have a corresponding recommended action. So for example, develop and implement a waiting list management policy which defines roles, responsibilities, reporting structure and a clarity of ownership. So where did the input come from for the recommended actions? Again, it came from best practice. It came from the hospital visits we conducted earlier this year, and it also came from the new waiting list policy. So the toolkit is aligned to the waiting list policy. The second part then of this, to add on to this solution part, if you like, of the toolkit, we try to make it quite practical in that we give examples of good practice from the hospital visits we conducted earlier this year. So the idea of this is that we wanted to demonstrate what hospitals have done, and also we wanted to, I guess, have this as a kind of like a signpost for people who you can talk to find out what they've done and how they've done it. So this particular example is related to data analysis. It's also important to mention that some of the hospitals outlined as good practice had their practices in place before we actually visit, and then other hospitals they actually put the example of good practice in place following our visit and the subsequent action plan that fell out from that. So an example here is that when we visited Our Lady's Hospital in Crumlin, they already had a pretty impressive SAP system in place for the analysis and presentation of data to facilitate data-driven discussions. And then the other side of that is the Mater Hospital, whom they developed a pretty impressive data visualization tool following our visit to help, again, facilitate those data-driven discussions with senior management and clinicians. So this example here will be showing some screenshots later on in the masterclass and data session, but also in the toolkit we have some screenshots of what they actually look like. So yeah, that concludes this session, but again I just want to finish by how I started to say that there is a lot of information in the toolkits. I would advise each of you in your own time to have a look through it, get a feel for what's there. If you have any feedback, Jenny Hogan in the NCPF and myself will welcome that. We'll be giving contact details at the end. And as I said, we do hope to make this interactive, put it online and add to it over time, that it becomes this, Bible, if you like, of support for improving performance. Thank you.